Hello, everyone. Welcome and thank you for joining us for our September episode of Chang Reaction. My name is Taylor Young, and I am the Assistant Director of the National Keratoconus Foundation. We are a patient advocacy program based in Southern California at the University of California, Irvine. NKCF provides information to patients and families and raises public awareness of this cornea disease. We invite you to visit our website, nkcf.org, and sign up for our newsletter and to register for our bi-monthly webinars. We also post news on our LinkedIn, Instagram, and Facebook pages. This is episode 18 of Chang Reaction, our Ask the Expert podcast. Our partner is Dr. Clark Chang, a keratoconus expert and friend of NKCF. We often receive questions about life with keratoconus, and Dr. Chang has offered to share his advice on these questions. You can view past episodes by going to nkcf.org/webinars. Dr. Chang is currently the Director of Specialty Contact Lenses on the cornea service at Wills Eye Hospital in Philadelphia. He is also a member of the medical affairs team at Glaukos, the company that makes the FDA-approved crosslinking product and equipment. He is a graduate of the Pennsylvania College of Optometry and a fellow of the American Academy of Optometry. Dr. Chang was also named the NKCF Top Doc in 2020. Welcome, Dr. Chang.
Hi, Taylor. Hello, everybody. Thank you for joining us.
Okay, well, we have some great questions today, so I'll just dive right in. And our first question comes from Narsing from East Coast Demerara, Guyana, who asks, what is OD keratoconus and OS keratoconus with apical scar?
Oh, thank you for that great question. And it shows, again, the good work that National Keratoconus Foundation is doing, that we have such presence of international audience. So again, thank you so much for submitting that question. So perhaps useless factoids, but I think very important here, that in Latin, OD means oculus dexter, which together means the right eye, whereas OS means oculus sinister. And yes, I know that it sounds a little ominous, but it really, and you probably guessed it, it means simply the left eye. So as we know, keratoconus can present in different severity in each eye. And we also know that corneal scarring can occur in keratoconus eyes for various clinical reasons as the condition progresses. So one can then deduce from your description that you provided us that the left eye, the keratoconus with apical scar, is more likely the eye that has more advanced keratoconus condition than the right eye, because of the presence of the scar tissue noted in your description. And apex, or apical scar, means that's the location of the scar tissue is noted in the area that's protruded outward the most on the keratoconus cornea. And the location and the size of the scar area, and in fact, we have a clinical photo from my clinic that I want to quickly show you what we're talking about, just so you could visualize along with me and Taylor the difference between area with no scar and area with scar on a keratoconus eye. But when the photo comes up, you'll see that the location and the size of the scar area can also be very important, because in this case, you could see that you can see where the cornea is, and the cornea tissue normally is not visible, but in this case, because they are scarred, and you could see that it's in groupings or cluster and partially obstructing portion of the pupillary area that most people are looking through, in this case, this patient. So why am I describing that? Because then the size of the location of the scar relative to your visual axis, or the point that a patient is looking through, can be important, because that tells us how much functional vision we can help to rehabilitate with either glasses, or most likely in this case, specialty contact lenses. So the important thing is then to make sure that you do, given the notation of the scar in the left eye to consult your eye doctors to see if there's any clinical recommendations for you or for your contact lens design to differ or to be modified to better protect or reduce the tissue stress in that scar area of the left eye. So that I hope will be able to provide some help to you.
Great. Well, our next question is from Tissy in Colorado, USA. She asks, how does late onset keratoconus, she was diagnosed at age 48, differ from the more typical second decade onset during the teenage to college years? Is it a different beast? What do you expect in terms of progression? And she says, thank you in advance.
Well, thank you for the question, Tissy. It's a great point that keratoconus phenotype may be different in patients who start developing keratoconus later in life, as you pointed out, versus earlier in life, as in more the typical, possibly even pre-puberty, early teenage, or even younger. So while it's not clear if these two groups of patients are of a different type of or different genotypes, and by genotype, I mean the genetic makeup as it relates to keratoconus. So we know, but regardless, while that's unclear, we do know that these two patient groups typically follow different clinical course along the path of this condition. So what are the differences? Keratoconus that starts to develop later in life, patients in this group, they tend to present with less severe clinical signs and symptoms and also tend to exhibit a slower rate of disease progression. Whereas keratoconus that starts to develop earlier in life, patients in this group, they tend to present with more advanced presentation, even sometimes at the very beginning when they're first diagnosed. And they also tend to show a faster rate of disease progression and worsening of the condition. So the visual prognosis then is generally more guarded or worse when keratoconus develop earlier in life. And that is the reason that keratoconus patients need to be monitored regularly by their eye doctors to ensure the detection of the progressive keratoconus condition as early as possible. Because now that we have treatment available in US and FDA approved crosslinking treatment platform, and outside the US also crosslinking treatments available for our international audiences. So it's also worth mentioning, though, I think, since earlier onset typically, I had alluded to earlier onset typically leads to a more guarded visual prognosis, so that then children of keratoconus patients should also be screened more regularly and hopefully earlier in the stage of their lives by their eye doctors, and I would encourage for guardians and parents of such young patients to share the family history of keratoconus with their eye doctors, because it can be important to, can be helpful in earlier detection should keratoconus develop. Not that it definitely does, but in literature has shown that the risk level or the risk likelihood of a first degree family member to develop keratoconus can be a lot higher than general population without such family history. And lastly, we also know that there are risk factors associated with faster progression regardless of which group of patients you're in, whether it's the earlier onset or the later onset. So what are some of those risk factors? Well, one of the prominent one and one of the few modifiable one would be chronic and heavy eye rubbing to the eye. And I don't mean touching your orbital bones around your eyes. I mean actually rubbing on directly either over your eyelid or not, because some people actually can be quite rough with their eyes, especially with contact lens on the eye. But whether it's closed eye environment or open eye, I mean rubbing over the area of your cornea. Those type of eye rubbing can exert a mechanical stress to a tissue that had already been weakened by the condition. So it is important to also consult with your eye doctors on recommendations to reduce some of those modifiable progression risk factors as much as possible, no matter when your keratoconus begins to develop in life. And again, I hope that's helpful to you.
Great. And I just wanted to add also, a lot of patients say, oh, I don't rub my eyes, but maybe when you're sleeping, subconsciously when you're stressed, or you might not even realize it in day-to-day life. So maybe asking a friend or family member to point it out if they notice you doing it can make you more aware of your habits.
And that's such a great point, Taylor. Before we go to the next question, I wasn't going to mention this, but because some of these modifiable risk factors are not easy to change. If it were related to allergy, if it were related to dry eyes, there are topical, eye drops that can be used. But a lot of times, just like you pointed out, you could be rubbing your eyes as a habit, and you have been doing it for so long, you personally you're not aware of it because it's a second instinct. And it also could be there's a group of patients who actually, maybe they're more side sleepers, or maybe they sleep on their belly. And so when you have your arm underneath the pillow or over the pillow and you're sleeping against it, there's been some anecdotal information that have been reported that side of the eye tend to correspond to the worst stage keratoconus eye in keratoconus patients. And so I've noticed that lately I saw an infomercial with a pillow that has a groove to actually for somebody to put their hands in when you're sleeping on your side. And therefore, you're not actually actively compressing against your knuckles or your fist. So that may be something that can be helpful. So look into that as well.
That's really cool. I didn't even know they made that, but great options. And
I'm sorry.
the good news is this is something that once you get a handle on, you can kind of control it. So that may bring some peace to our keratoconus patients. Our final question comes from Linda in Georgia, United States. She asks, I have had keratoconus for over 30 years. I am now 71. Recently, I moved from California to Georgia, and about a year after moving, I noticed floaters in both eyes. The floaters are different in each eye. Is it common for people with keratoconus to have floaters?
Right. So Linda, again, thank you for submitting the question. You may actually, great timing, because you're likely part of that late onset keratoconus group that we were talking about in the prior question, deducing from the timeline of having been diagnosed with keratoconus, or keratoconus first developed over 30 years ago. So the different floaters, getting back to your question, the different floaters in your vision from each eye are unlikely to be directly associated with keratoconus. However, these visual floaters, or floaters in your visions, can actually be commonly found in general population with or without diagnosis of keratoconus. And I'll show you a photo so that you can see where the keratoconus, where the floaters are coming from. And so there's an illustration that I want to show you. And obviously, again, with the illustration here, there are two main fluid-filled chambers inside of the eye to maintain the shape of your globe. The first one is filled with fluid called aqueous chamber, and that is right behind your cornea, but in front of your iris, the color part of your eye. The next chamber, larger chamber, is called aqueous humor, or is filled with vitreous humor. I'm sorry. So it's more of a jelly-like substance, and it's behind the lens of the eye, right in front of the retina of the eye. And so where Taylor's circling for me here, it's more of a jelly-like substance, less of a water-like substance, such as the aqueous chamber that we talked about. So this vitreous chamber, as you can see, is filled with that jelly-like substance that condenses over time. And so as it shrinks and the structure is collapsing within that chamber space, it also comes along with the pockets of different density, because the structure is shrinking and condensing. And that different level of density will cast shadow on the retina, or the photoreceptors, where that's on the level of your retina. It'll get picked up as different degree of light, and therefore it's perceived as shadow in your vision. And we call them floaters because they will move around depending on the direction of the motion of the eye. They'll move around like snowflakes moves around in a snow globe when you shake them, right? So because it's light transmissions through these different density area, because of that, these floaters are most noticeable in bright environments, such as when it's sunny outside, or when you're looking at monitor screens that are lit up, or TV, or even just white color walls. And generally, these floaters will slowly sink to the bottom of the globe, and that's why they do become less noticeable over time until these floaters are again stirred up for circulation in the chamber pending the motion of the eye or surrounding lighting. And I'll show you a photo of what it looks like clinically here, where you could see the brown circle is the color part of the eye of this patient, and you can see two areas that has grayish ridges that's floating inside of that vitreous chamber that I'm talking about. Those are condensations of that jelly-like substance that when light hits it, casts the shadow in the back of the eye, and you perceive them as floaters. And so the people with higher, we know a known risk factor of, even though floaters can be detected in large percentage of general population, and in fact most people at some point in time will see floaters in their life, but people with higher prescriptions for nearsightedness or myopia like myself are more at risk of having earlier onset or seeing these floaters more often or more commonly. And because as with nearsightedness, the eyeball gets a little bit longer, so that stress as the eyeballs elongating, the stress exerting to the jelly-like substance inside of the eye can make it so that those patients with higher prescription of nearsightedness can see those floaters earlier in life or more commonly in life. And for example, I have been seeing floaters since I was in grade school, but fortunately they have not changed at all for me. But so the other important aspect is not just that you started seeing those floaters, which I hope you had gone to your eye doctors and had a dilated eye exam. But the other important aspect is to also have regular dilated eye exams and to monitor these shade floaters, as well as for you to report any changes in the shape and size, and because especially if you experience any episodes of light flashes or anything that's blocking your vision in either eye. The reason I said that is because these symptoms are commonly reported in patients with retinal detachment, but also overlap with symptoms that's reported by people with seeing these floaters. So the only way or the best way to differentiate those is to have your eye doctor examine you inside of the eye while after you're being dilated. So make sure that you do have regular eye exams, that if any changes that we've discussed, to go and see your eye doctors sooner than your regular eye exams and as soon as possible. So hopefully that clears up the matter of whether or not floaters are related to keratoconus condition.
Great. And then just out of curiosity, is there anything someone can do to kind of not stir it up? I know you mentioned when the eye movement is kind of more shaken, it does something, or it appears more. So in my mind, I was thinking, okay, don't go on roller coasters, but is it a little bit more simple than that, where just walking around maybe can stir them up?
No, you're right. Typically, it's either due to some form of trauma, and obviously that cannot be controlled outside of protecting yourself a little more, because as those structures are condensing and collapsing and sort of contracting away from the retina, added trauma externally can then also possibly lead to more potential for retinal detachment, and you don't want to have that. So obviously avoidance of trauma, if you're seeing these floaters that have been diagnosed by your eye doctors as regular floaters and not exerting any type of health threat to your retina. But what would you bring up a good point. What else can you do outside of just letting it go through its physiological process of condensation? So obviously neuroadaptation is actually the best way, because usually either your brain gets used to enough stimulation so it ignores the signal. That's one reason we don't see our blood vessels in the back of the eye. We technically should see it all the time, but because it's there constantly, your brain filters it out. So it's best to kind of just try to get used to it. And certainly if you move your eyes, if you change your direction of your gaze, what you're fixating on, side to side, up and down, you will be more likely to stir it up. But it should settle down rather quickly, especially if your brain had already adapted to these signals. So really that's it. There's not really, any magic that we can perform outside of letting your brain and letting the vitreous chamber, shrink and condense on its own. It is in rare situation, we could surgically remove the vitreous jelly-like substance. Sometimes it's done at the same time with your cataract surgery if needed. But typically, if patient can get used to these disturbances of the floaters, we don't usually like to perform surgical options, as you can imagine.
Understandable. Thank you. Well, that was all of our questions. Thank you to everyone who submitted. And next month, look for another chain reaction episode with answers to more questions about keratoconus. And along with that, if anyone listening has a question that they would like answered in an upcoming episode, you can go to the nkcf.org website, and under the For Patients tab at the top, scroll down to Ask the Expert Chain Reaction, and you can post your question there and we'll try to answer it in an upcoming episode. Finally, NKCF operates with the support of friends and donors. And so if you feel the urge to support us, you can make a much appreciated online gift to the UCI Foundation. And with that, thank you so much, Dr. Chang, for another great episode. And thank you to everyone again for submitting questions.
Thanks, everybody. See you next time.